Mel, you have disabled my video. So here it is. Thank you so much, Meryl. And good evening, good afternoon, good morning to all of you. We have more than 110 participants already joined the meeting. It's our February webinar of the ISSM webinar, Oncosexology, Sexuality and Cancer Survivors. It's a great pleasure to welcome you all. My name is Annamaria Giraldi, and I'm the president of the ISSM. For those of you who have not joined us before or might not know the ISSM, I just briefly want to introduce to you that the vision of the ISSM is that every human being has the right to a healthy and satisfying sexual life. We also have a mission, and we would like to be the most respected and trusted source of information, education, and professional development of human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange all over the world. And our series of webinars is a part of this mission and vision, and we're very happy you're joining us today. Another way to come out with especially research results are our journals, and I just want to put your attention to our journals, Journal of Sexual Medicine, Sexual Medicine Reviews, and our video journals. And they are all included in the ISSM membership in case you are not already a member. So it's a great pleasure also to tell you that we still are working on, we'll have our meeting in Japan in November 21, but these webinars were developed as we were not able to have our meeting last year in Japan as planned. So in order to continue our vision and mission, we have developed these webinars, and we are very grateful for people still joining and our education committee that are planning so many exciting and interesting webinars. So to begin, I would like to introduce our moderator for this webinar. Our moderator is Sharon Bober. Dr. Bober is a senior psychologist and the founding director of the Sexual Health Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. She's also an assistant professor in the Department of Psychiatry at Harvard Medical School. And Dr. Bober has many clinical and research interests. Among these, her focus are on sexual health, cancer genetics, and cancer survivorship. So she is the perfect person to moderate this webinar. Welcome, Dr. Bober.
Thank you so much. It's a pleasure to be with all of you today, and thank you for that introduction. I just want to say good morning from Cambridge, Massachusetts, and give everyone to start with a sort of an overview of our program today. We will hear from three fantastic speakers, and then we will have really a good opportunity to have some conversation for questions and answers for probably about 30 minutes. So encourage everybody to have those questions, put them in the Q&A, and I will take note of those, and we will use those to really to get the conversation started. So just to begin with, it is again my great pleasure to introduce our first speaker, Lisanne Hummel, who will speak with us about cancer survivorship and female sexual health. Lisanne Hummel works as a psychologist and postdoc researcher at the Leiden University Medical Center in the Department of Psychosomatic Gynecology and Sexuality and Psycho-Oncology. She obtained her PhD in the Netherlands Cancer Institute, and her project was entitled Internet-Based Cognitive Behavioral Therapy for Sexual Dysfunction After Breast Cancer. Thank you so much for being with us today, and Dr. Hummel, we look forward to your talk.
Thank you for the introduction, Sharon. And I will tell you today about cancer survivorship and female sexual health. Yes, thank you, Meryl. Yeah, sexual problems are a frequently occurring long-term consequence of the treatment of cancer, and the prevalence and nature of sexual dysfunction differs across cancer site, stage, and treatment type, and is influenced by individual factors, of course. And the prevalence of sexual problems in gynecological cancer, breast cancer, and colorectal cancer is higher than 65%. And although the consequences are especially high for these types of cancer, people often don't realize that the treatment of other types of cancer can affect sexuality too, such as in bladder cancer, head and neck cancer, hematological malignancies such as leukemia, and lung cancer. And the average prevalence of sexual dysfunction after cancer is 50 to 60%. Next slide, please. Patients report sexual problems as the third most prevalent long-term consequence of cancer, and sexual challenges may persist many years into survivorship. Next slide, please. All modalities of cancer treatment have the potential to negatively impact sexual function, and I will talk you through the sexual side effects of the most important treatments in the next slides. Yes, first surgery. This is a busy slide. I won't mention everything, and I will talk you through some of the aspects. With regard to surgery for gynecological cancers, this can lead to vulva, vaginal, and clitoral alterations, such as vaginal shortening and tightening, changes to external genitalia, and damage of pelvic nerves. After a mastectomy, but also after breast conserving surgery, changes such as scarring, pain, and loss of sensation in the breast or nipple occur. Lymphedema in the arm can change body image, but it can also complicate the use of certain sexual positions. And in head and neck cancer, difficulty swallowing, breathing, a decreased saliva production, and disfigurement can occur. And wearing a stoma can alter body image and can bring insecurities during sex, for example, if the stoma might leak. Next slide, please. Chemotherapy can also have multiple side effects. For example, loss of hair can affect a woman's feeling of femininity and sense of self. A neuropathy changes touch and can make touching painful, which can impact touching and caressing during sex. And furthermore, chemotherapy can lead to premature ovarian failure with abrupt early menopause, leading to, for example, vaginal atrophy and dryness, and decreased sexual desire and responsiveness to sexual stimuli. And it's not only the symptoms of menopause that affect a woman, but also the loss of fertility might do so. Next slide, please. Endocrine treatments. This is used, included in treatment of hormones positive cancer, such as hormone receptor positive breast cancer, and it blocks estrogen receptors or stops estrogen production. And it's given up until 5 to 7 or even 10 years after diagnosis. And it often causes vaginal dryness and atrophy, dyspareunia, loss of desire, but also vulvar pain when sitting or cycling. Next slide, please. Radiotherapy can lead to scarring and skin thickening, drier mucous membranes of the vagina and the mouth. And pelvic radiotherapy can lead to vaginal changes, incontinence, sudden urgency, and changes to genital sensitivity. And brachytherapy, which is vaginal radiotherapy used for example, cervical cancer, can lead to vaginal shortening and tightening. And these women are advised to use vaginal dilators to prevent this shortening and tightening. Next slide, please. Stem cell transplant. This is part of treatment for example, leukemia or lymph node cancer, and it's combined with chemotherapy and full body radiotherapy. And patients can develop graft versus host disease, which is an immunological reaction in response to the transplant of the donor cells. And it includes, among others, red spots and a rash on the skin, dryness, skin thickening, nail dystrophy. And it can also affect the vulva and the vagina with dryness, pain, and stenosis, itching, and scarring. Next slide, please. Well, after mentioning all these changes that might affect sexual function, it's important to underscore that sexuality is, of course, a multifaceted construct. So it's not only the sexual function that has changed, but also the sexual relationship in which partners have to find each other again after the period of diagnosis and treatment, and maybe sexual scripts have changed between partners. And also the sexual identity of the woman, which might have been impacted by the bodily changes or loss of fertility. And women do not only need to deal with an altered body image, sexual response, and erogenous zones, but also with the role switching from sexual being to being a patient and back to a sexual being. And the same is true for the partner, with the role of partner, caregiver, and sexual being. And maybe there is loss of sex as relaxation or stress reduction, or loss of trust in the body. So yeah, the many etiological roots of sexual dysfunction and distress are interconnected and complex, with physiological, psychological, and social factors interacting to influence sexual well-being. Next slide, please. Well, here I've listed some of the risk factors for sexual dysfunction after different types of cancer. And it's important to realize that women are at high risk for developing sexual dysfunction after gynecological, breast or colorectal cancer. But also when there were sexual problems before diagnosis. And also wearing a stoma, infertility, negative body image, physical quality of life, sexual communication between patient and partner, and mental quality of life put women at higher risk for developing sexual problems. Next slide, please. So always be aware that if a patient doesn't mention sexual changes, it doesn't mean that there are no sexual changes. Patients really appreciate it when the healthcare provider initiates the discussion. Next slide, please. And in a review article of Rees et al., 64% of men and only 28% of women were informed about potential treatment effects on sexual function. And only 14% of patients queried their healthcare provider about their sexual problems, and 21% of the healthcare providers took the initiative to assess sexuality. And this demonstrates that, fortunately, sexuality is discussed, but that the percentages are quite low compared to the percentage of patients that experience sexual problems and that might need help. Next slide, please. So it's important to discuss and assess sexual problems as it helps the patients to prepare for potential changes, to cope, to adapt to a new balance, and to renegotiate sexuality with the partner. And it also normalizes and validates the patient's experience and concerns. Next slide, please. So when discussing it, it can be helpful to realize that you don't have to solve the problem, but you can give permission to discuss it. And that fits the implicit model of addressing sexual functioning, in which you first give patients permission to raise sexual issues, then provide limited information, followed by specific suggestions, and then refer to intensive therapy. Next slide, please. So how to take this first step of giving the patient permission? I've listed some sample sentences here, which are all related to a particular approach. For example, a treatment-related question that you could ask is, a mastectomy with breast reconstruction can affect sexuality and body image. Have you considered how this might affect you? Or if it's after treatment, has this affected you? And the prevalence-related question is, sexual changes such as decreased desire and pain during intercourse are known side effects of the treatment of leukemia. How is that for you? Or you can also use an oncology or post-treatment related type of question. And it's helpful to have a few sentences like these prepared for yourself and to familiarize yourself with the wording and the tone of voice. Next slide, please. And after giving permission to raise the issue, you can, for example, use the sexual symptom checklist or another screener if you want to query the patient a bit more about sexual problems. Next slides. Well, then to round off some practical tips, start a conversation at an early stage, return to the topic regularly, include the partner in the conversation. Do not forget unpartnered patients, and also don't forget older patients. Ask about the level of sexual functioning before diagnosis, as problems can be long-standing and can be aggravated by cancer treatments. And have information folders or websites that you can reach out or recommend, and know which specialists you can refer to. Next slide, please. And with the multifaceted nature of sexuality in mind, you can provide the patient and partner with some strategies and solutions. So advise patient to communicate openly with the partner about the changes. In decreased desire, it can be helpful to focus on what is pleasant and to try and find new or other sexual stimuli. In dyspareunia, you can advise non-coital sex or the patient to take more time for higher arousal and to use a lubricant. And for vaginal dryness, you can advise a non-hormonal vaginal moisturizer in hormone-positive breast cancer, for example. When there's loss of erogenous zones, it's about rediscovering the body and developing new erogenous zones. When fatigued, patients can choose another time of the week or another time of the day, or a non-coital sex or sex without an orgasm. And you can also discuss intercourse positions with the patients. For example, after cervical cancer, less deep penetration might be needed, or when fatigued, a less tiring position can help. And vibrators can be advised for additional clitoral stimulation. Vaginal dilators can be used to prevent vaginal shortening and tightening, for example, after cervical cancer. Yeah, you can see how many of the tips for managing sexual dysfunction after cancer are about renegotiating sexual difficulties or sexual activities, or the sexual scripts, rediscovering sexuality, and searching for new and other sexual stimuli. Next slide, please. So the take-home messages are: sexual dysfunction can occur after treatment of any type of cancer. Patients appreciated being queried about sexual changes. Talking about sexual problems after cancer prepares, normalizes, and helps to cope and adapt. It's good to have a sentence prepared to introduce the topic, and also to have information booklets and websites available, and familiarize yourself with referral options. Thank you for your attention.
Thank you, Dr. Hummel. That was fantastic. I appreciate your talk. And again, anybody has any questions as we go along the way, please put them in the Q&A. It's my great pleasure to now introduce Professor Eric Chung, who is a urological surgeon at the Andro-Urology Center in Brisbane, Australia, and holds academic appointments in the University of Queensland in Brisbane and Macquarie University Hospital in Sydney. He is the Secretary General of APSSM, the Chair of the Membership Committee at ISSM, and the Chair of the Prostate Cancer Survivorship Committee at the last International Consultation on Sexual Medicine. Dr. Chung, we're looking forward to your talk today.
Well, thank you, Sharon, for the nice introduction. Good afternoon, good morning, good evening, good night to all the attendees at the ISSM webinar. It is a pleasure to be invited to the education webinar again. Given that the majority of data that we know about cancer survivorship and male sexual function are derived from prostate cancer survivorship, my presentation will be focusing on prostate cancer survivorship specifically. Given the time limit, I will try to provide a very brief overview and share with you some of the important concepts that our committee has been working on. So we know globally that about 9 million men around the world will be diagnosed with cancer on an annual basis. And obviously, when we talk about male sexual function, we focus predominantly on pelvic cancer, given that there is a direct link to sexual health and also sexual functioning. We know around the world that prostate cancer and also colorectal cancer account for more than 30% of cancer in men. And of that, we know that prostate cancer is the most common solid organ cancer in the Western country, and in developing countries as well, prostate cancer is rapidly catching up with lung cancer as being the primary cancer suffered by men. Next slide, please. So the question we have is going to be whether is this a biological issue related to the men having more likely cancer, and also whether the presence of cancer in men are more likely to be serious. So there could be potentially a biological factors, as we know that there is more cancer diagnosed in men than women. This could be related to perhaps a risky behavior with smoking and drug and alcohol use, perhaps related to occupational exposure due to their work environment. We know that there are significant psychosocial cultural issues related to men with health-seeking behavior, and that probably result in some of the poor adoption of health prevention measures, including delayed presentation and also management. And this potentially could translate to more advanced and serious cancer. We also know that the presence of cancer has significant impact beyond health in terms of the economic impact. There's also the impact on the masculinity factors, and also in terms of whether the men feel invincible with cancer. Next slide, please. Now, the impact on the LGBTQI community is poorly understood at this point in time. And this is likely to translate to poorer treatment options and also support networks. So I think this is an area that is rapidly emerging and certainly require a lot of focus in the coming years. Next slide, please. Now, several important concepts I'd like to share with you. So cancer survivorship program aims to improve and maintain health and well-being of the patient, while at the same time try to reduce disability related to cancer and treatment. We know that penile rehabilitation program is considered the standard of care in men following prostate cancer. It is aimed to maintain sexual function and, more importantly, also to preserve the penis health. Next. The concept of masculinity is very important in men, especially in the setting of prostate cancer survivorship. The question of masculinity, whether this is related to underlying psychosexual issue or perhaps related to other factors that are non-sexual or has social cultural component to it. Next slide. The concept of sexually active life expectancy is a very important concept because we do know that cancer are more likely to occur as the men get older. And we're also likely to understand that in older men, perhaps sex may carry a different significance to this man. So we know the concept that aging can certainly affect sexual health. We also know that physical functioning and the development and progression of medical comorbidities can sometimes play a significant role outside of just the cancer impact on sexual health. Next slide, please. Now, obviously, the presence of erectile dysfunction is the main focus with male sexual function. Obviously, I will acknowledge that there are other male sexual domains and other factors that are equally important. But let's focus on erectile dysfunction. This is likely dependent on the type of cancer that the man has and also the subsequent treatment being received. The majority of data are derived from prostate cancer, and it's estimated that up to about 60% of men would have erectile dysfunction with robotic surgery, and those that have radiation tends to have erectile dysfunction at the later date, and those that have hormonal therapy are likely to have less recovery of their erectile function. As mentioned before, penile rehab remains the standard of care. In men that have intact neurovascular bundle, PDE5 certainly work, but otherwise the men should be treated with intracavernosal injection, vacuum device, and psychosexual counseling. Penile implant at this point in time remain an effective option for those that have medical refractory cases. Next, please. Well, apart from erectile dysfunction, obviously the changes in sexual desire, libido, ejaculatory and orgasm dysfunction are important sexual function that can be affected. Next. Outside of sexual function, we need to also address the presence of other organs that may be affected. For example, in pelvic organ disease, you get development of urinary dysfunction that range from climacturia, incontinence with orgasm, to full stress incontinence. Other organ complications from bowel and cardiovascular disease can also impact on the man's sexual health and also function. The use of polypharmacy and drug dependency is a big issue in this group of men. There are significant psychosocial cultural issues, for example, effect on the mental well-being, body image, confidence, and changes in relationship dynamics are important issues to be considered. Not to be discounted is the impact on cancer on the financial employment factors, because this can certainly impact the social setting of the man. Next, please. Now, when we look at treatment option, we need to address some of the factors that can be associated with treatment failure. For example, we know that in men with prostate cancer, corporal oxygenation and prevention of penile fibrosis is critical to maintenance of sexual function. It's important that any patient that have treatment for cancer should also have an informed discussion and to have the treatment for cancer prevention and also addressing some of the sexual function as early as possible. It's about trying to understand what are the drugs that's available or what are the therapy that's available to try to escalate the treatment strategy accordingly. It's important to try to be aggressive at the early stage because prevention is very important in this group of men. As the men develop treatment adverse effect, it's important to try to address them as they develop this, and also maintaining that this cancer-related complication certainly can be addressed and also treated. Psychosocial support network is very important. As I mentioned before, it's important to treat other domains of sexual function beyond just erectile dysfunction. Next, please. Now, sexual rehabilitation is a very complex topic. Certainly, there's many unmet needs in this group of area. The majority of literature for male sexual function in cancer survivorship are derived from prostate cancer. It's about adopting the clinical guideline that's currently available in a very personalized manner. The current strategy should focus on penile rehab protocol, but also emphasizing on non-coital sexual intimacy and partner satisfaction. We need to be aware of the complex factors at play here. Biopsychosocial model with a holistic approach in a very multidisciplinary model should be the way to go forward to try to address all these relevant factors. More importantly, it is about a shared decision making and to ensure that the patient continue to receive strong supportive care. Next, please. Preparation and prevention measures are critical because it allows the patient to think ahead of time and also allow us to be able to address those issues as they come about from the cancer treatment. Next, please. Over the last few years, there seems to be significant emphasis and also interest in terms of the medical hype of regenerative therapy. For example, microenergy low-intensity shockwave certainly has been adopted by both the ISSM, SMSN, and APSSM as being a useful modality, but in the setting of clinical experimental. The data on shockwave therapy as penile rehab in prostate cancer is limited at this point in time, and we know with any treatment option, it's important to select the right patient group. At this point in time, we certainly will advocate caution in the use of shockwave because the patient demographic is different to the standard erectile dysfunction group. Next, please. Cellular-based technology with stem cell and platelet-rich plasma certainly has significant hype and also significant commercialization. At this point in time, it is safe to report that there's limited clinical data despite very robust basic science. The long-term efficacy and safety data certainly are lacking, and given the setting of commercialization and aggressive marketing for many of these centers, it's important to understand that there needs to be a government regulation to try to keep everything in track. Next, please. And lastly, over the last 5 years, there has been a lot of interest or renewed interest in the use of nerve regeneration through nerve transfer. The clinical science certainly is questionable in the demographic of patient where there is underlying corporal fibrosis and also the likelihood of spontaneously recover the nerve in the setting of pelvic cancer surgery. The clinical outcome at this point in time seems to be limited to several centers, but had not been replicated by other centers around the world. Next, please. So the take-home message is that the majority of data that we do know about cancer survivorship and male sexual function certainly derive from prostate cancer survivorship. Penile rehabilitation is accepted as a standard of care. The aim is to try to encourage spontaneous erection and to preserve the penis health. In terms of cancer survivorship and strategy to try to recover the sexual function, it's appropriate to try to escalate the treatment accordingly and in a very holistic and multidisciplinary manner. We need to understand each therapeutic option can have some limitation. Sexual rehabilitation should focus beyond penile erection, and at this point in time, regenerative therapy certainly warrants counseling and consent. So thank you again for the time to be involved, and I look forward to the Q&A time.
Thank you so much, Dr. Chung. That was terrific. And again, please feel free. There was a lot of information packed into that talk, and feel free to put the questions in the Q&A. It is now my pleasure to introduce my colleague and good friend, Dr. Daniela Wittmann, who is a clinical professor in the clinical associate professor, in the University of Michigan's Department of Urology. She's a psychotherapist, educator, and researcher. She is also an ASEC certified sex therapist and sex therapy supervisor. Dr. Wittmann has published on sexual issues in prostate and bladder cancer, and her research focuses on developing and testing interventions that support couples' sexual recovery after cancer. So without further ado, Dr. Wittmann.
Thank you very much for the introduction, and I want to thank ISSM for inviting me to join this illustrious panel. Next slide, please. I have no disclosures. I want to start with some quotes from patients who've had sexual problems after cancer treatment. So starting with, my body has changed and I don't feel things the same way I used to. Or, I'm too tired and depressed to think about sex. Or, I don't have anything to offer my partner sexually anymore. Or, I'm not me. Or, suddenly I feel old. Next, please. Next slide, please. So as was mentioned before, we look at sexuality as a complex experience. My colleagues previously spoke about the various ways in which the body can be affected by cancer treatment. And you can imagine that if people lose body parts that are relevant, sensitivity, they are fatigued, or they have pain, they begin to feel the impact on sexual function. And they begin to have feelings about how they are as lovers, as sexual beings. This could give rise to anxiety, to depression, to fear that one can no longer have pleasure or become a good partner to one's partner, if there is one or a future one. And you can imagine that if there is a partner, the partner notices what the patient is struggling with, and beyond being concerned about the partner, realizes that even for him or her, sex life probably will change forever and will no longer be the same. We know from research that couples don't always communicate effectively, and that can lead to additional problems within the couple. All of us live in complex societies with multiple cultures and religions, and we have to consider when working with our patients the impact of those on their ability to talk about sex, talk about what's acceptable as sexual activity or rehabilitation. Next slide, please. Next slide, please. So we can think about patients going through sort of a journey in their sexual recovery. They come to it with a certain level of sexual functioning and couple sexual functioning, and then they are diagnosed and treated and develop side effects of treatment. There is a concept in the bereavement literature called a psychosocial transition, and I added the bio for obvious reasons. And it is defined as an event in one's life that is so significant and impactful, then one can no longer go back to baseline ever, that it unalterably changes how one relates to oneself in terms of one's body, one's feelings, one's thoughts, and even how one relates to the outside world. So having sexual problems after cancer, of course, cancer is the event too, can be that unalterable event. And I see this a lot with prostate cancer patients with whom I generally work. The loss of sexual functioning is profound, and for many patients it's ambiguous because some have a partial or maybe even full recovery, and some never do recover sexual function in the way they used to know it. And as you can imagine, loss ushers in grief and mourning, and patients and their partners have to then work through this process to get to some level of sexual functioning with what they have left. And they have to sometimes re-eroticize their bodies and develop a new template for sexual experience and interaction. Next slide, please. So how do these patients get to psychosexual therapy? So some of those patients I call the accidental therapy patient. So there are programs, oncological programs that within themselves have the availability of sex therapists. And so suddenly the patient who finds himself or herself talking to a sex therapist realizes, oh, we have some long-standing problems that we really should address, and this is an opportunity to do so. Or we are feeling so kind of frightened of what's ahead of us, we want to have some psychosocial, psychosexual support. And then there is the other patient that we have to identify, and that's why it's so important for the clinicians to bring up sexual health. It's the disenfranchised grief experience that some patients have when they feel that once they've been treated for cancer, they don't have a right to ask for help for other things, such as their sexuality that sometimes even seems frivolous to them, they don't realize that it's a very important part of them that we can, as clinicians, address. One of the things that I have found is that patients often think that sex therapy is basically tips and tricks. And of course, there are those. But in fact, they discover that sexual recovery is very hard work. Next slide, please. So when we see patients with sexual problems who've been through cancer treatment or before cancer treatment even, of course, we are aware that cancer and its treatment affects all parts of sexuality, and that it ushers in these losses that I've mentioned and others have mentioned too. And patients cope using psychological defenses, which sometimes are unhelpful, such as denial or compartmentalization to a degree that people begin to avoid sex, etc. Or they can be helpful, like reframing or having a perspective or optimism. We have to understand that as mental health providers, that sometimes people sink into conditions that require psychiatric help, such as depression and anxiety. And we also recognize that we have to address all parts of sexuality in treatment, sexual dysfunctions, the person's response, couples dynamics, and rehabilitation. Next slide, please. When we do a psychosexual assessment, first, we want to understand the patient's understanding of the impact of cancer and treatment on their sexuality, because a lot of education has to take place. We assess the psychological response, that's where the defenses come in, and coping. We assess how the partner is responding as well and how the relationship is doing. Taking a sexual history is very important because we want to understand both the functionality with which people came to their cancer experience, but also the attitudes, the earlier experiences that will then color how they're going to recover and cope. We also want to know about their personal history because any significant relationships or events might be impactful, and those may include the experience of sexual abuse or trauma, which can be also very influential. The history of mental illness informs us about the patient's particular vulnerability and whether they've dealt with the mental illness and how. We also understand that sexual function and sexual recovery will be affected by substance use and comorbidities and medications, and we need to assess that as well. Next slide, please. So as I've mentioned, loss and grief are very central to sexual recovery when patients want to retain their sexual relationships. But what is lost? Many things: physical self-image, sexual self-image and confidence as a sexual partner, familiar sexual interactions and familiar sexual sensations. All of these have to be reconfigured in the new setting. Next, please. We generally warn patients that they may experience grief during their first sexual encounters as they start becoming sexual again. This comes as intrusive thoughts that they may be thinking while they're trying to make love, thinking about what it used to be like, what it's not like anymore, worrying about whether they're going to be feeling pleasure and orgasm, worrying about whether the partner will be satisfied, and generally feeling sad about things not being the same. We understand that grief, unlike many other conditions, is something that people can work through if they face it and deal with it, and that it can diminish. And in their sexual practices, people can become more competent and capable and emotionally connected, and that can be a very successful recovery in spite of sexual dysfunction. Next, please. There are a number of methodologies we use in psychosexual therapy. We, of course, attend to physiological remedies, but in individual therapy, we, of course, do grief work, but we also use cognitive techniques, such as, for example, reframing the experience. Let's say with prostate cancer patients, often they feel that if they don't have erections, they're no use to their partners, and they have to be reminded that sex is really a much bigger concept, and they have to realize that they still have sensuality, capacity to orgasm in most cases, and they can be still good lovers to their partners if they're sensitive and thoughtful. We have learned from research that mindfulness can improve focus, which becomes very important to these distracted, worried patients. The psychodynamic approach helps us identify the use of psychological defenses against grief and fear of the future, and help modify them so that they are better for the patient's recovery. And I already mentioned that education is just ongoing. Next, please. In addition to this, if we are seeing a couple, we also have additional approaches. We analyze interpersonal responses to reduce conflict and to improve collaboration so that people can feel like they're on the same team. We use sensory focus exercises to reduce anxiety and to gradually get people to sexual interactions through sensual activities. We teach sexual communication. You'd be surprised, but in research we found that couples can have perfectly good sexual relationship for 40 years and never talk. And now they have to talk to inform each other about what works and what doesn't work. And we get patients to try to experiment with new sexual activities, new positions, new tools, so that they can expand their sexual repertoire. Next, please. The goal, of course, is for patients and for couples to feel like they can be again sexual, that they can have pleasure, that they can exchange information with their partner to maximize their experience, and that they can perhaps expand their sexual repertoire. We want them to feel competent and good about themselves and not anxious and depressed. Next, please. In all of these efforts, we collaborate with other specialists, of course, medical providers, and particularly also with physical therapists who specialize in pelvic floor rehabilitation. Sometimes we involve cultural or religious leaders when that becomes necessary or useful. So let me now next get to the take-home points. Next, please. So for all of you who practice in the area of cancer, please find a local mental health provider with sexual health expertise and make friends with them so that you have a colleague who can help you. Ask your patients always, and their partners, if they are partnered, how they're coping with their sexual changes, because then you normalize that sexual changes are something to attend to. Normalize their feelings of loss and grief, and the fact that sexual recovery is hard work and that they may need assistance. And then let patients know, if they are interested, how they might be referred to a local mental health worker with sexual health expertise. Thank you very much.
Thank you, Dr. Wittmann. That was terrific. And I am really delighted to see that we have a lot of, I think, really great questions as well. So if the speakers would like to turn on their cameras, presenters, and we can dive right in if that's okay. Several people, Lisanne asked about the question of intervention for women. I know Dr. Chung spoke in detail about some of the specific interventions for men. You've recently published an intervention that was sort of an internet-based intervention. And sort of first question really has to do with asking you to explain a little bit of the pros and cons, shortcomings and advantages of this kind of intervention. In this case for women, perhaps we can talk about that a little more broadly, but why don't you go ahead?
Thank you for the question, Sharon. Yeah, indeed, it was an internet-based cognitive behavioral intervention that we evaluated for women who had sexual dysfunction after breast cancer. And yeah, the pros of such a program are that it is accessible. People can follow the treatment in their own time, even if that's in the night. Also, there might be a lower threshold to seek treatment. And also the feeling of anonymity is helpful to some people because, yeah, sexuality is still a topic that people often don't feel very comfortable about talking about it to other people. So the anonymity of internet and typing your response can really help people to open up and to talk about the topic and to lower discomfort.
Could you share a little bit about the content of the intervention that might be helpful for people to hear?
Yes. Yeah, there were 10 modules available. So first, women would start by clarifying like which sexual problems they were experiencing. They received psychoeducation about sexuality and sexuality after cancer. They received information about the biopsychosocial model. Important other topics were partner communication, coping styles with regards to the sexual problem, exploring the changed body, also sensate focus exercises alone and with the partner. And of course, the cognitive restructuring part was also one of the parts of the treatment. And yeah, sexual needs, new sexual stimuli, sexual development. So yeah, and then the therapist would choose the modules that were most suitable for each patient. Right. So very broad program.
Thank you. That's terrific. And just a quick question. Somebody asked, where was that published? So if you could just give a brief shout out to where that can be found.
Yeah, it was the Journal of Clinical Oncology. We published the main results there. Yeah.
Okay, terrific. Thank you so much. Dr. Chung, we have a number of questions for you about penile rehabilitation, specifically time frame. You know, it might be helpful if you could share a little bit about the sort of you know, what is the optimal time frame for when men need to be thinking about this? Is there a time frame with which it is sort of beyond the scope of repair? And if you could just speak a little concretely about not just penile rehabilitation, but also anything we know about work that needs to be done on the front end before men have surgery. To preserve.
Yeah, there's a very big and comprehensive question. So essentially for penile rehab, it's about trying to recover spontaneous erection as early as possible, at the same time preserve the penile length, because many of the patients that have erectile dysfunction also would complain about loss of penile length. So that's actually a very legit symptom that can be quite distressing to patient. So the whole premise of penile rehab is to try to start it as early as possible. So in patient following radical prostatectomy, as soon as the catheter is removed, the patient should be instituted with the appropriate penile rehab program based on the surgeon preference. At this point in time, the literature on the ideal penile rehab drug and also protocol do not exist. There's certainly a lot of conflicting information, but I would probably try to hit the patient as hard as possible and as aggressive as I can. So I would probably escalate the treatment accordingly. So for example, if you use oral PDE5 drug, you really want to make sure that the nerve is working, because if the nerve has been affected with neuropraxia, it may take up to about 6 to 12 months for the nerve to recover. So during that period of time, to preserve the penis length, intracavernosal injection and vacuum device could be very useful in that group of men. So in men with prostate cancer, it's also important to understand that there is this new concept whereby with pelvic floor rehab, people do it before the treatment in order to improve the pelvic muscle tone so that they don't develop incontinence. So the concept whether we can actually institute a pre-treatment penile rehab program to try to improve the penis health so that you have more reserve before you actually lost it. The clinical data about penile fibrosis, there's a very wonderful paper that was published more than 10 years ago by the Italian group who biopsy men's penis after prostate cancer. I'm not sure how that goes to the ethics, but essentially showed that even as early as about 2 weeks, there's significant scarring that occur. So with penile rehab program, start early, be aggressive, and escalate it as appropriately.
Okay, terrific. Thank you so much. A number of questions, Dr. Wittmann, I think you might be able to address have to do with, one, how do we better incorporate the partner into the treatment process? And similarly, how do we incorporate oncologists better into the care of sexual health as part of treatment and survivorship? So 2 pieces to that, both having to do with how do we better incorporate both partner into care and oncologist into the rehab process?
You know, so I would say that the first question is easy. The second one is quite difficult to answer. The best way to incorporate partners is to invite them to all appointments with the patient. There are very few situations where the patients don't want their partner to be there. Most of the time, they welcome it. I know with prostate cancer patients whom I treat, they sometimes feel that their partners know them better than they know themselves, and so they really welcome the partner's presence. It gives the patient and the partner the message that the partners are important and that partners also need support and information, and it certainly furthers the work afterwards. So they should be involved in all the education, all the decision-making, and then all the rehabilitation activities afterwards. So that's the first part of the question. You know, I think that incorporating this into oncology care really requires, quite frankly, some kind of one champion of visionary physician in a group or in an academic setting who recognizes the biopsychosocial aspect of sexuality and recognizes that these patients really suffer. I know that in our program, we have an embedded sexual recovery program in oncology care, and really it came because patients advocated. Patients came and said, why are you not providing this for us? And that's kind of how it eventually developed. I think there's probably enough literature out there now about the importance of all of this. So then you have, you know, people like Dr. Chung, who kind of understands this and who was promoting it in his talk today. They had, you know, so I think the biggest influencers are patients and other physicians. And I think the mental health providers will happily come along.
Terrific. Thank you for that. You know, several people have asked really about the idea of patient-reported outcome and assessment, you know, and I think this really goes to each of you. Question is, are there any instruments, measurements measures that you use in a systematic way or in a regular way to add to your clinical practice? Lisanne, do you want to start?
Yes, thank you, Sharon. No, in my clinical practice, I don't really use patient-reported outcome questionnaires with regard to sexual functioning. Yeah, I just ask about it in the conversation. But a frequently used questionnaire is the Female Sexual Function Index. Yeah, that's an internationally used questionnaire with regard to sexual functioning that I would recommend. That you could also use as a screener or to see in what areas a woman experiences problems.
Thank you. Dr. Wittmann, Dr. Chung, any thoughts on measurement assessment?
Yes, so the University of Michigan is a part of a statewide urological surgery improvement collaborative called MUSIC that many people around the world are familiar with. And in this group, as a part of this group, we collect EPIC data, the Expanded Prostate Cancer Index Composite, which addresses all the, you know, sexual, bowel, urinary function at 3-month intervals. And we also collect one item from the PROMIS measure of sexual satisfaction and sexual interest. So we can use this in clinical practice. It varies how much clinicians actually do use it. And we are currently in the process of wanting to develop a collection, also assessment of psychosocial outcomes, such as dyadic couple scoping and grief response, because we found in our research that those are important variables.
Great, thank you so much for that. Dr. Chung, anything you'd like to add in terms of assessment, measurement with patients on this topic?
Well, I echo the statement made by Daniela and also Lisanne. Most of the time, we use a lot of validated questionnaire in the setting of clinical research. But in real life, I always find that the 2 questions I use quite useful would be, number 1, what exactly is going on in your life, in particular from a sexual function point of view. And second is about what can I do to try to improve your quality of life from a sexual function point of view. So I think sometimes asking a very simple question actually are quite useful because patient can volunteer you some information.
That's great. I was just reading this morning a note from Dr. Michael Perelman, who I think many of you may know of, his comment in the context of a sexual assessment. He said he always asks his patient, tell me about your last sexual experience. I think that's an excellent question that certainly elicits a lot of information in terms of real-time function. So we have some other questions that I want to get to. Certainly a number of people ask about just how to get training in this field, right? I mean, certainly we have this webinar today. I know that I certainly will put a plug in for some of the work that I do around this, but I really want to throw this out to all of you first. How do folks get more training very specifically about cancer and sexuality, how to treat this, and what to do about it? Because although I think there is certainly a growing interest, certainly I've seen that significant shift in interest over the last, let's say 10 to 15 years, there's still a lot of question about how people get training in terms of how to do this work. Dr. Wittmann, do you want to start?
Sure. So I'm sure that Dr. Chung is going to speak about how urologists can be trained. So I don't have to, speak about that, even though I know about it. So in mental health and in sexual health counseling, there are a number of programs. One program is in Canada. It's in prostate cancer, where there's, I think, a 13-week online program that international students have taken. The person to contact about this is Dr. Andrew Matthew at Princess Margaret Hospital at the University of Toronto. At the University of Michigan, we have a postgraduate sexual health certificate program, which people from multiple disciplines attend. You can get your CMEs there and your CEs as well. And that's a year-long program which focuses on sexuality, not necessarily on cancer, but chronic illness, including cancer, is included. It's kind of the academic portion of the certification to become a certified sexuality counselor or therapist through the American Association of Sexuality Educators, Counselors, and Therapists.
Thank you, Dr. Wittmann. Dr. Chung, any thoughts about training in this field?
Well, completely echo Daniela's comment. I think two important points I'd like to make is number one, sort of putting on the head of the membership committee chair for ISSM. ISSM is a wonderful place where members can actually ask questions, where do I need to go for training, and also ability to engage different experts within the ISSM community. So I think this is probably a very useful area where members who are interested to pursue further training in this area can contact the relevant expert. The second point I'd like to make is that the patient himself or herself is actually a good trainer, because they'll tell you what exactly is happening in their life and what they wish to address. And you can always try and error different treatment modality with this to see which one will work and which one doesn't work, and you learn from it. So I think patient himself or herself can be a very fantastic teacher as well.
Thank you, Dr. Chung. And on that note, I will also mention another organization that I am very involved with, the Scientific Network on Female Sexual Health and Cancer. This is an organization that is devoted specifically to the treatment of girls and women and female sexuality after cancer. And again, sort of lots of specialized training opportunities, CME courses, and valuable information on our website. Happy to put that in the chat box. So please feel free to check out the Scientific Network, certainly around female sexual health. I do want to sort of get to a couple of more questions. I think we have a little bit more time. Several people have noticed or commented on the fact that depending on the aspects of this area, there really is a lot of research, or there really is a lack of research. There's really a range. A couple of people asked about, very specifically, what are the gaps in care? What are the kinds of research initiatives that we really should be focusing on, specifically in the context of oncosexuality? So Lisanne, would you like to take that to start?
Yeah, gaps. Well, I think in the past few years, there has been more research into sexual therapies that are also effective for treatment in sexual dysfunction in cancer. But I do think more research is needed, and also more research on programs that can be implemented after they have been evaluated. I think that's a big gap, not really in research, but it is a big gap in the consequences of research, because a lot of times, the programs don't get implemented. So then the patients that have been included in the randomized controlled trial have benefited from this program, but not, the patients out there. So I think, implementation is an important future aspect of research.
Thank you. Dr. Chung, any thoughts in particular around gaps that people need to be focusing on right now?
There are plenty of gaps. In fact, I think there's a lot of emerging studies, especially in the current climate of gender fluidity, non-binary. What's the sexual function, expectation, and treatment outcome for the LGBTI community in those that are terminally ill? Because we do know that some of the terminally ill patients do and wish to engage in sexual function. So I think these are probably some of the areas that are quite important to have more information.
Okay. Dr. Chung, another sort of question that is very specific, which I do want to ask about, we heard about this in a couple of questions. People ask about the VED. If you could explain a little bit specifically about why you think that may be either underused or not used adequately in the course of rehab, and also thinking about uptake. Often I think men get that, hear about it or get a recommendation and don't use it. Maybe Dr. Wittmann can also speak to why that may or may not be the case, but let's talk a little bit about that.
So VED is about vacuum erection device. I think one of the biggest issue with VED use is that men sometimes overestimate the size of the penis. So when they purchase VED device, they buy the biggest device that actually not appropriate for their penis. So I think that's probably one of the reasons why they found that VED doesn't work. The literature about VED is quite interesting, is that on one hand, VED actually can prevent penile shortening, but at the same time, if you use it too aggressively, it can also create damage. So I think the use of penile VED has to be tailored appropriately, and also patients need to be aware that you have to be very compliant with the treatment. It certainly is not a useful treatment as a monotherapy, but certainly very useful if you use it in conjunction with other treatment modality.
Great, thank you so much. And Dr. Wittmann, do you want to speak a little bit about that? Because that certainly is as much as an issue for couples as it is for individuals.
Yes, yes. So, at the University of Michigan, we use it as a part of penile rehabilitation. And there is a variety of responses. Some men and couples find it such a mechanical and sort of unspontaneous thing to use that they reject it out of hand. I think many men, when using for penile rehabilitation, think of it as a sex toy, and then they don't like it, and you have to convince them that it's sort of like going to the gym. It's rehabilitation. It's not really a sex toy. And so the mechanical nature sometimes is very difficult for some people. Other men are completely responsive to it and realize what this does for them, and are very pleased that they have to use that they can use a non-invasive methodology for creating erections, because many men don't want to use injections, and PDE5 inhibitors don't work for them. So that becomes a really, really good option. I have had a few engineers who are fascinated by the mechanism, and so they use it. And a couple of men have come to me at the end when their spontaneous erections started to come back and said, "Do I have to stop using it? I really like what it does for me." So it's a really varied response, and you just really sometimes have to psychologically work with people to understand why they're using it and what it can do for them.
Thank you. I think we just have a couple of more minutes left, but I do want to actually get to a question that a number of people have sort of touched on, which I appreciate is complicated given that we're talking about the whole world. But the question really has to do with, how does this get paid for? Does insurance pay for this? Is this part of standard care? So I recognize that that's going to vary significantly. I think we have a participant from the UK who said that they definitely have trouble in the UK getting private insurers to pay for this kind of psychosexual work. Could somebody speak to that issue around payment and insurance? Dr. Chung, do you want to start that?
Obviously, it's very different for different country. For example, in Australia, if you have private health insurance, certainly it's covered by the private health insurance if you develop complication related to your cancer treatment. For those that are uninsured, the government do have a system in place where a lot of the public hospital can offer similar therapy. So I think it's important to sort of understand that there are a lot of non-government organizations. They are really sort of being a very strong advocate in this field. And I think at the same time, it's always trying to increase more awareness so that the public can actually drive this. Because if the public put a demand on the government, then the government would then be forced to do something about it. So I think increased awareness and also better education for the patient certainly will help to push this forward.
Thank you. I think that certainly echoes a point that Dr. Wittmann made before, which is that it sounds like we're all in agreement that there needs to be a patient empowerment piece around this and an advocacy piece that is coming as much from patients and survivors as it is on the provider side. Does anybody else, either Lisanne or Daniela, want to speak to this question about how to access care?
No, I mean, just basically that it's so unavailable that's where online interventions become relevant because they improve access, but they have their limitations as well.
Okay. Thank you so much to each of our participants. This is a lot of food for thought, and I would like to hand this back over to Dr. Giraldi.
Thank you so much. And first of all, thank you, Sharon, for moderating this perfectly, bringing up all the interesting questions. Thank you to all the participants for asking so many really, really good and interesting questions. And thank you to Daniela, Eric, and Lisanne for excellent presentations. I can see from the chats and the questions and answers that people have been so astonished by your good presentations, and it has really been interesting. A little comment to where to practice. I really like that your approach, Eric, that and also as Lisanne said, that if you use the please-it model, I mean, try to start to talk to your patients about sexuality. And I think this webinar is a good inspiration to do that. And it has been mentioned a lot of different places where you can train, but I especially want to emphasize the ISSWIS if you work with women. Eric talks about all the initiatives about for prostate cancer men. We have ISSM, which is really have the strengths that we have regional societies. So try to find your regional societies and see what you can do through your regional societies. There will be courses and inspiration for the work. And also, as I mentioned in the chat, the ISSM school, which is a little bit longer course, but also a possibility of training and learn how to talk about sexuality if you're not used to do that. So I just want to thank you everyone for being here. We have been more than 250 participants, and for the first time, this is a historical moment, we had participants from all over the continents, because this time we had one participant from the Antarctic, and that's the first time we had that. So that's really nice. So 7 continents were represented at this really, really lovely webinar. So I just want to thank you all, the presenters, the moderators, the participants, and also invite you to our next webinar, which will be March 25th, and that will be on pregnancy and sexuality. And I really hope to see you all again, and please invite anyone you think that might be interested in participating in this. So take care, stay safe, and hope to see you in March. Thank you.
Thank you.
Bye-bye.
Thank you.